All right, good afternoon. I'm Andy McNeil with my co-host Matt Duffield here with another edition of Free Arkansas. Matt, how are you doing? Are you excited about the guests we have today?
I'm very excited, Andy. Good to see you. Welcome everyone to Free Arkansas. We have today the doctor of the house. We have Lee Johnson from Greenwood, Arkansas. You know, I'm going to give you a moniker now a representative that, you know, I try to give some wrestling names. I think your moniker should be Lee Soulman Johnson. So
I love it.
Welcome today, ladies and gentlemen, the hardest working man in the House of Representatives. And I mean that 100%. Dr. Johnson, Representative Johnson, representing Greenwood. Thank you so much for taking your time. I understand you're coming to us from Austin, Texas today.
Yeah, I had to come down here for work. I do some administrative work with critical access hospitals, rural hospitals, and I've got some work to do down here in Austin area. And so I got off work this morning in the ER at Crawford Memorial and got on a plane in Fort Smith and in Austin today, tomorrow, back in Little Rock for public health, and then working Wednesday night in the ER again. So
because a rep's work is never done, I imagine, right? Is that what you're going back in for? I guess a meeting of some sort in that
we
state
have
house?
public health meetings this week, and then and then back to work in the ER Wednesday night.
And Lee, how long have you been in the House?
So I'm in my fourth term. So,
Okay.
This is my seventh year, fourth session. When I finish this term, I will have been serving for 8 years.
Got it. And you still have, I guess, the term limits allow you to go a few more years, correct?
In theory, I could go 16. That seems like a frightening proposition at this point. Check back with me in a month or two. Coming right out of the session, I'm not sure I've got 16 in me, but.
Well, what we thought we would do with you today is just talk about, just broadly speaking, healthcare in Arkansas. And what I wanted to do is maybe to start at the high level. You know, before we got on, we were talking about just lists and where Arkansas sits in list and even the numbers behind the list. But putting the numbers behind the list, one of the things that I would say about Arkansas broadly is we rank lower on a lot of the lists related to healthcare. So on our website, you can see various lists, but one list is just the state of the health of the state. And we're 47th in that list. And I'm just curious, with your experience as an ER doctor, when you hear something like that, knowing maybe other states, et cetera, does that align? Do you sit there and go like, yeah, that's probably true?
Yes, to some degree, right? I mean, I see in the emergency room, I have a bit of a skewed view because I'm seeing more unhealthy people more often, right?
Yeah.
I mean, people don't come to the ER because they're feeling good. They come to the ER because they're sick or they're having some sort of issue. And so I admittedly have a little bit of a skewed view after, 25 plus years of working in emergency rooms in Arkansas. That said, when you look at those lists of, where we rank in healthcare, it's looking at things like access to healthcare. And obesity,
Yep.
and there are incidents of diabetes, incidents of cardiovascular disease. All of these things sort of build on each other, and so it's hard to rank high in healthcare when you rank high in obesity, diabetes, cardiovascular disease, all of these other determinants of health. Right. And including in that some of the social determinants of health we talk about, education and poverty. There's a lot of things that feed into that healthcare ranking. And so when you look at where we rank in these lists, you can see to some degree or another why we struggle with health in Arkansas.
It's almost like you could break our state into a couple different states, or maybe even more than that. And just, at least in terms of maybe healthcare access, I know that there's been a number of rural hospitals that have closed over the last 15 or so years. And I believe I'm right when I say that a couple different cities basically passed, I don't know if it's sales tax or what sort of funding mechanisms, but to keep their local hospitals open. Are you aware of those sorts of things in the state?
Yeah, it's a really difficult time for rural hospitals. And some of that is because medicine has changed so much. Medicine has gotten a lot more complicated. And in some ways, that's a good thing, right? I tell people when I started out in 1999, I started in Fort Smith at what was then Sparks. And if you came into my emergency room in 1999 with a stroke, I would walk in and go, man, Andy, Matt, gosh, I'm sorry. It looks like you've had a stroke. We're going to get you over here to rehab and cross our fingers and hopefully get you feeling better. Maybe get some recovery back, right? Because that was the treatment we had. And then right about the early aughts, we started, studying these clot busting medicines. And then it was like, hey, if you can get to me within 3 hours of symptoms and you meet these criteria, I may be able to give you this clot busting medicine that will reverse your stroke. And then it was 3 hours to 6 hours. And then you fast forward a little bit more and it's, hey, now we've got this procedure where we can put a catheter in your wrist, right? And we can run it up to your middle cerebral artery in your brain.
It's crazy.
From your wrist.
Yeah.
And we can suck out the clot. So in a 25-year time span, just when you look at how we treat stroke, we've gone from there's really nothing I can do for you to now, if I can get you to somewhere, if the circumstances are right and I can get you to the right kind of specialist, they can actively remove the clot that's causing your stroke. So, if you think about, and that's happening on multiple fronts in healthcare. And so in, 1980s, 1990s, if you were in, a rural hospital in Arkansas and you had a stroke, well, there was really no need to transfer you anywhere. You didn't really need to see a neurologist, right? Because they could take care of you there. And it's the same way with almost any type of disease process that you mention now. You're going to want to see a specialist, and it hasn't always been that way. And so, that makes it financially challenging when the model is for a rural hospital, when the financial model depends on how many admissions you can keep in your hospital, right?
Interesting.
And so you're transferring all of these people out to the urban centers and that trying to figure out how you replace that revenue cycle over time and how you change strategies, the rural hospitals are having to either come up with some sort of way to subsidize themselves through like a tax,
right?
Or they're having to change, their business model. And that's where, you get around to these, people shifting to critical access hospitals or rural emergency hospitals, people, a lot of these rural hospitals doing swing beds and trying to fill up their hospital with, these patients that are more like nursing home patients versus acute care patients. The business model, for these rural hospitals has got to change if they're going to stay financially viable, or they're going to need some kind of subsidy. And that's where, a local tax can help.
Interesting. Can I summarize that? And then Matt, I'm going to throw it to you. Okay. So one way to think about it is as medicine has progressed, and you didn't mention this, but you not only do have a specialty focus. So now I know a lot about sucking something like, in your example, a clot out of the brain, but I imagine the equipment is also more specialized, more expensive, right? That you might need enough of a throughput to make it make sense. That what's offered at, say, Fort Smith isn't the same thing that's offered in DeWitt. For the
right, exactly. And if you rewind time, your business, we talk about average daily census in rural hospitals. This is how many patients do you have on average, in your hospital, right? And some of these rural hospitals in the 80s, 90s, even the early aughts, they might have 20 or 30 patients. And now a lot of these rural hospitals, the average daily census is in the single digits. And that's because to a large degree, we're more dependent on specialists to take care of cardiovascular disease, GI, pulmonary, neurology, all of these folks. I was in a meeting Matt, you're technically River Valley. I don't know how I sort of bridged the River Valley in Northwest Arkansas right there in Fort Smith. We talk about Fort Smith being the River Valley, but we're also in Northwest Arkansas. And during the session, the 3rd Congressional District had a healthcare caucus come to town, and some of the CEOs from some of the hospitals that are in Northwest Arkansas were meeting with legislators. And I asked the CEOs of those hospitals, now these were more urban hospitals, if I could triple the number of primary care doctors you have right now, or triple the number of specialists you have right now, what would you choose? And every one of them chose specialists,
Really?
right? Yeah, I asked that question on purpose because I wanted the legislators to hear that, because hopefully we're going to talk about the shortage of PCPs we have, because we need both. But it's easy to lose track of the fact we're not only starving for primary care physicians, we're starving for specialists as well, and it creates a backlog in these urban hospitals, because there is these guys that I was talking about that run the catheter from your wrist to your brain, right? They're interventional neuroradiologists. I don't think there's more than, there can't be more than 8 to 10 in the state. There may not be that many. And so, if you qualify for that, you're going to have to go to Little Rock, Fort Smith, Northwest Arkansas, one of the major hubs. And, it's the workforce issue in healthcare is sort of pervasive, but understanding that concept, I think of like how specialized medicine has gotten, and sort of acknowledging that that's not a bad thing. We're better at curing disease and making people healthier. It's expensive, and the system hasn't really caught up to that mechanism of delivery yet. We're still having growing pains, especially in the rural systems, and to some degree the urban as well, trying to adjust to this new era of modern medicine that's so dependent on specialists.
Matt, what question do you have?
Well, Lee brought up this shortage, and everyone I speak with, and almost every industry has a shortage. Could you elaborate more on why is there this shortage? Because from my perspective, looking just at the medical field, when I was growing up, seemed to be a lot of people that wanted to be doctors and get into that field and feel like it was a good living. Why is there a shortage, I guess, specifically in when it comes to specialists?
Yeah, I think to some degree there's there's an increased burden of people to take care of. We're seeing this group of older people sort of hit the healthcare system, and there's more demand, I think. And as medicine gets more complicated, there's more demand as well, right? Because, when used to your family doc could take care of everything back home, now that's not how we're constructed. And so you need more people to take care of a stroke, right? If before the way you took care of a stroke was you just hope they got better and gave them some rehab, you might not need that many people. Now, when you're having these, specialized interventions, then you need more people to take care of the same disease entity. So I think there's been an increase in the need for healthcare types of healthcare workers, coupled with an increased demand, because we're keeping people alive longer. They're having more health issues as we have an aging population. And then, Matt, we have, just a pervasive workforce issue in Arkansas. I mean, when unemployment's, I don't know, what is unemployment in Arkansas? 3.5%?
Small. It's a low number.
I mean, we have a people problem in Arkansas. We don't have enough people for, if we're going to keep growing the market, we've got to get more people to move to Arkansas. The economic development principles of, let's find a big land and let's get a big factory to move and give them some tax credits and, build a Mitsubishi plant somewhere. I mean, that's not what moves the market in economic development. It's workforce. You got to have a supply of skilled labor to get people to come to town.
Matt, I've got a question, but you might have a follow-on before I jump in.
No, go ahead.
I'm curious. I want to talk about the patients here, but I want to talk about the doctor side for a second. I'm just curious if you have an opinion on this. As just somebody who just goes to the doctor every once in a while, I guess I have these two different, maybe not conflicting thoughts, but on one side, when you talk about if I have a stroke, I for sure want the person that's snaking the tube up from my wrist to my brain to really know what they're doing, right? Yeah. Very experienced, very trained. On the other side of the equation, though, I take a statin and I go in regularly every once in a while to get, my blood taken, as an example. And one of the things I find frustrating is that I'd have to actually go in, get an appointment, even in Russellville where I'm friends with my doctor. I mean, I probably could bypass the system, but I'll go in there and I sit there and I go do I really need, for lots of things, strep test, getting the statin, et cetera, do I actually need a doctor? I mean, like, could it be someone who's gotten trained like for a year, or some other year? And so I wonder if part of the future is, yes, we have certainly highly trained people that are doing very specialized things, but then a slew of people that are sort of generalists that are just doing the 101 things. Is that a thing, or like, no, everybody has to?
Man, it's a thing. We've got to change it. So on a couple of fronts, like, I'm a little more permissive than some of my colleagues on these scope of practice issues. I was the guy that helped draft the bill that let pharmacists both diagnose and treat strep and flu. That's one of my favorite.
That's a great thing
that we did, right? I mean, and we not only did we do that, we empowered pharmacists to prescribe over-the-counter medications. Like I remember I was riding home with Justin Boyd, a senator. He was a representative at the time from Fort Smith. He's a pharmacist, and I was talking to him about this bill. This was in 21, and the pharmacists were wanting to do all of these things that I thought were a little bit of an overreach, right? And we were trying to find some sort of compromise that physicians could live with, but still sort of expanded pharmacist scope. And we're riding in the car, and I'm like, Boyd, what would make this bill work? And he goes, what really is frustrating from a pharmacist standpoint, Lee, is, we would like to be able to prescribe over-the-counter medicine. I'm like, what do you mean, man? And he goes, well, some insurance companies will pay for diapers, sugar, the sticks, the little glucose sticks that you do for your glucometer.
Yeah.
That's ibuprofen, Tylenol, and if we could just write a prescription for that, it would save us calling you and interrupting your day. And I'm like, well, yeah, we don't care about that. Like if I write a prescription for some diabetes medicine and I forget to write the prescription for the glucose strips, I don't want you calling and stopping my day to say, hey, Lee, can you prescribe this person glucose strips? Just you prescribe them. And then he was like, the other thing that would make sense is like, sometimes, the insurance will pay for one class of drug, but not the other one. And so this happens, this was happening. They would stop and call and talk to the doc, and you'd be like, hey, this guy, Mr. Smith's insurance will pay for, this H2 blocker, but not that H2 blocker. Can we switch? And I'm like, yeah, why are you even calling me? Switch it.
Yeah.
And so, those kind of things create some common sense places where, you're facilitating access to care, and we just haven't had that communication to find where that is. So I think there's some low hanging fruit around, making sure people are, from a common sense perspective, practicing to the highest level of what they can safely do.
Because I almost sort of think that there's all these simple things that happen, right? And that, you get a cold or whatever, and you just are looking for the lowest level of care. And we maybe could make that easier and more accessible than somebody who spent their entire 20s, getting a doctorate degree,
Well, I think, one of the things that I'm trying to promote, I think there's an opportunity as physicians. We need to change how we train ourselves. Right now, if you want to train a primary care physician, it's going to be 4 years medical school and 3 years residency. So 7 years.
Right.
Now we're starting to look at a 3-year medical school. That UAMS has a program. There are other schools that are having sort of a 3-year track to condense the training in medical school from 4 years to 3 years, which you could really safely do. What I want to see happen next is I want to see us condense the residency training from 3 to 2 for primary care physicians. Because right now, when you talk about a primary care physician, you're talking about either a family practice doc, internal medicine, pediatrics, which is a little different because they just do kids.
Right.
In med peds, those are the residencies you think about. OBGYN is kind of a primary care, but not exactly. Those are all 3 or 4 year residency programs. When we're teaching our family practice docs, we're teaching them to take care of patients in hospitals, deliver babies. Some of the studies out there say that only 16% of family practice docs deliver babies.
Yeah.
And only 20% go to the hospital. So why are we spending all this time teaching them to deliver babies and go to the hospital if that's not what they're going to do? So I think there is some, to your point, there's some opportunities to train smarter and then have sort of a two-prong approach where, okay, we're going to train primary care physicians and we're going to emphasize preventative care.
Sure.
We're going to educate them on this value-based concept as opposed to fee-for-service. And then we're going to have this separate track where we speed up some of the training of specialists, because that's the other problem too. Like if you want to be, if you want to be a interventional cardiologist, right? The person that goes in and puts stents in your heart. Well, you have to do a 3-year internal medicine residency, and then a 2-year fellowship in cardiology, and then you go and do your another fellowship in interventional. Like the 3 years of internal medicine, we're teaching you all sorts of things you're never going to use as a cardiologist, right?
It's a little bit like calculus is your first year in college that you're never going to use again.
Yeah, I mean, there's definitely, like, I think to fix the workforce problem, at some point we're going to have to evolve as professionals, as physicians, how we train. And nurses are doing this. I mean, when you look at some of the things we've done to address, some of the things being done to address the nursing workforce in our state and other states has been around changing the number of hours they can train through sim labs as opposed to in person, right?
Yeah.
And so wherever you are on the healthcare spectrum, sort of pausing and rethinking, why have we always trained us this way? Is there a better way to think about training us? And then to your point, is there a better way to access care? Do you really need to go to your doctor's office if you just want lab done?
Yeah. I almost think that AI, like I've got a friend who's uploaded all of this blood work into ChatGPT, literally took a picture the other day of the menu and it said, eat this, and I think people are going to trust that as they go forward in some ways.
Yeah.
Matt, what you got?
Man, there's a lot to talk about, and I know the clock is ticking, and I know you're in Austin and you're busy, but I'll say this, there was an old saying, an old joke. It said, never trust a bald barber with your hair. And, Dr. Johnson, when he walks into a room, people look at him and say, hey, this guy's a really healthy person. And so you live by, I believe, health. I don't see a giant cheesecake hidden behind you and pack cigarettes, but anyway.
Don't follow me too close, man. You might find me at Taco Bell, but I appreciate that. I'm trying to live a good example.
Well, I guess the question I would like to ask is, you've been an ER doctor now for over 20 years, so you've seen all kinds of situations come in there. If there was one thing that you could say, hey, you're an Arkansan, do this, and it'll help your overall health, or maybe not even one thing, a handful of things. What advice would you give just to the common Arkansan about their health to help improve that? So, the workload of our medical system is down if someone would just do X, Y, and Z to make themselves healthier.
Yeah, for me, it's obesity and smoking. I mean, those are the two biggest things. When you look at the healthy states, they're going to have a low obesity rate and they're going to have a low adult smoking rate, right? And so whatever we can do in Arkansas to curb obesity and to curb smoking, and like fully recognizing that it's not somebody's fault necessarily, right? Obesity is a disease, right? It's not your fault you have diabetes. It's not your fault you have, people say, well, I can just exercise my way out of this. Well, maybe not, right? There are genetic things and a lot of predisposing things, and a lot of it goes back to childhood. And it's the same way with nicotine addiction. Nicotine's a legit drug, man. Yeah. If you've ever been exposed to nicotine, which if you were raised in Arkansas, at some point you probably were one way or the other, right? Like it's that's a monkey that will get on your back. And so I don't want to make it sound like simple for people to quit smoking or to quit. But I think if I were going to wave a wand and fix two things in Arkansas from a health perspective, those two things tie back to all the other health issues that we see.
Okay. I want to flip to Medicaid, and talk a little bit about that, but I'm curious as like a segue, what's your view on these peptides like Ozempic and Majuro and stuff? I view them as transformational on so many people that I know.
Tool in the toolbox, right? I think there's, if I'm going to sit here and say that obesity is one of the things I would change, and we've stumbled upon this medication that truly works. I mean, all of us know people. I mean, it works, right? And why are we not embracing that? Why are we not trying to say, hey, the cost savings down the road from making people less obese, maybe that's worth the upfront cost of these medications. And it's not fair. Yeah, like it's hard to sell cost savings to insurance companies a little bit, right? To commercial payers. And, they're big on value-based, wanting to shift from fee-for-service, reimbursement models, which, if people don't know, I mean, fee-for-service is a volume-driven revenue thing. So the more clicks I get, the more I get paid, right? And it doesn't matter if I'm doing a good job, bad job. There's no quality tied to it. With value-based reimbursement, you're tying, certain quality measures, performance measures to how a provider gets paid. So, a portion of your payment is maybe withheld, or maybe you get an extra portion of payment if you're doing these preventative things, and so that concept of saving money downstream by paying money up front is something we should buy into, but it is, getting a dynamic fiscal impact on something like that can be hard. But I think, for me, if we can pay for a medication that's going to reduce obesity significantly, we should figure out a way to do that. I think it should, we should figure out a way to cover it.
Be interesting. I know that in the federal Republican bill that just passed, they've got a tax, I don't know if it's a credit, a reduction, I don't know exactly how it's stipulated in there related to going to the gym, which also is sort of interesting. What's also interesting and a bit shocking, and I don't know how it really compares to other states. So, I mean, maybe this is not out of line with other states, but I suspect that that 1.2 million Arkansans, approximately, so a little less than 40%, but right at 40% of Arkansans are on Medicaid. Now, to be on Medicaid, you have to be within, I think, 120% of the poverty line, and there's various different tests. But let's just say a family with kids, it's something like, $35,000 a year. And so that's a huge number. And then you double down on 2 points, and then I want to get Lee your impression, and then Matt, I'd like your thoughts on this too. So 25% of those are estimated not to have a primary care provider, which means they probably don't go to the doctor, and so maybe they're not actually consuming the Medicare expenses. And also you couple with this, and you didn't mention this earlier, but I imagine you see this as an emergency room physician, but Arkansas ranks last. And this is one I imagine people wouldn't debate us on, but in terms of Medicaid reimbursement, and this is also true with Medicare, by the way, so
it's true with commercial payers.
Yeah, and commercial payers too. So you get sick, the same thing happens in Massachusetts, same thing happens here. We're going to get paid less.
Oklahoma,
or than Oklahoma. Yes.
Louisiana. Matt and I worked on a bill this session that would have mandated. So this is so. What the bill would have done is it would have mandated commercial payers pay hospitals, reimburse hospitals at 50% of the average of our surrounding states. So I want you to think about this. I said this in my testimony, okay? So I just imagine whatever your profession is. You're a plumber, you're an electrician, you're a CPA. Let's imagine that I want to create a fair reimbursement model for you. And the way I'm going to do that is I'm going to look at all the surrounding states around us, Texas, Tennessee, Louisiana. I'm going to say, you know what? You should be paid at least as much as the average of everybody around us. And we're going to make sure that as a floor, you're going to get the average of all of our surrounding states. You would say, well, that seems pretty fair, right? Of
course.
And then what if I said to you, now we're not going to give you the average. We're going to give you 75% of what everybody else around you is making.
You think you're getting gypped. You would
think you were getting screwed a little bit, right?
Yeah, of course you would.
And then what if I said, well, we're not going to give you 75%. We're going to give you half of what the surrounding states, half. You're getting half. And in the hospitals, they all wanted that. Their reimbursement is so low, they were wanting not 100% of the average, not 75% of the average, half of the average commercial rate. And
why
we couldn't get it
like
passed.
This pass?
You couldn't get it passed. And I'm like, what work environment is that a fair reimbursement model where you're getting, and this is hospital reimbursement. This is, anyway, it's shocking to me that that's the part of it that was shocking to me. When we were working on this bill and I was talking to hospital administrators, I'm like, does that really help you? And they're like, yeah, this will help us. I said, once we say half, we're setting that's kind of the ceiling. Yeah, if we could just get half of what everybody around us was getting. So you wonder why there's hospital closures. I mean, to some degree, it ties back to this reimbursement issue.
Yeah. Matt, what are your thoughts on when you hear these numbers?
Well, Representative, Andy, this was a bill that came to the House floor. Representative Jeff Wardlaw presented it. And I'd just like to get Representative Johnson's thoughts on, obviously I was a yes vote. I supported it. I did what I could to try to help the cause. And I know you were supportive. If I'm not mistaken, you spoke in favor of the bill. But ultimately, the bill failed on the House floor. Why do you think that was?
And I get the concern. I think the biggest concern is around, premiums going up, right? So if we mandate increased reimbursement, there's the concern is that the commercial payers will then be forced to pass that cost on to all of us that are paying commercial premiums. And we know commercial premiums they're significant. This is a significant part of your monthly income is going towards premiums. But my thing is like, why does it have to be? Why is that the only choice? How much money are the insurance companies making? And how about we not pass it on to premiums? How about we pay hospitals more and maybe the insurance companies make a little less? Yeah. I mean, where's the transparency around, what are their profit margins and where are they at? And is there a way to sort of, and, I want to be fair to the payers, but also watch out, technical issues. I want to be fair to the payers, but also, I fair to Arkansans, right? I don't want to increase the burden on the common Arkansan paying premiums. I just think there's a way to do this where it doesn't have to be either or, where we can increase reimbursement to hospitals and keep premiums reasonable.
Yeah. Well, to me, like the big Houdini move is how do you simultaneously move up the rates, improve the obesity, get people off Medicaid, right? Because so we can move that number down. That's a lot to sort of do, right? And I'm not really sure that I'm aware that, like, off the top of my head, what I would think a great, what the best plan is around that. But it's certainly something we should be aiming for.
For sure. And I think it's like, how do you eat an elephant? It's one bite at a time. You find incremental successes. You make policies to try to increase workforce. We've made investments in graduate medical education to try to improve the number of residency slots we have to train physicians. We've tried to expand rural health scholarships to not just physicians, but to other healthcare workers to push people out into the rural community. We're doing things to actively try to attract people to the state of Arkansas through a variety of different measures. I think there are, you have to have this overall vision of where you're trying to get to. We're trying to move up on these lists. We're trying to get people off Medicaid. We're trying to improve the health of Arkansans. And then you have to start incrementally making the small changes that lead to that long-term goal.
Do you guys view like what you see in the House, or just, I don't know if this is a thing, but I suppose one of the reasons why such a large number of people don't have a primary care physician it may not have anything to do with laziness or anything. It may just not be that there's a primary care physician in their county, because we've got 70% of the counties that are designated as primary care shortages. So you got guys that are overworked, not enough of them. I perceive that we try to bring in people from other countries, and I don't know what we make them do in terms of, gee whiz, you got your MD at whatever school and, with the country you're from. But is there resistance from people in the House about, oh, that's an immigrant coming into the country? Or do people smart enough to say, we need a bunch of doctors here, let's let them in?
Matt, I would be interested. We passed a bill that Senator Hester and I sponsored around international medical graduates and trying to facilitate their licensure in Arkansas. There were some obstacles we're trying to remove. What's your feeling? I get a skewed opinion because I'm in the medical community. What's your feeling on trying to improve access and facilitate, highly educated international graduates to come to the state?
From my view, it was a non-issue. I mean, I never heard any rumblings about international doctors or people from other countries in the medical field, this is interesting because I'm sure you remember, there were a lot of rumblings when it came to international folks driving trucks on the interstate. So it was interesting where there was a rumbling about that, and there was some legislation that they should speak English and so forth to drive trucks on the interstate. But when it came to the medical field, I don't think anyone thought anything of it, perhaps because they're accustomed to going to the doctor and there are people from other countries in those positions already, maybe. But no, that's my perspective.
It was a good bill we passed. I think part of it was, we went through the medical board and went to the medical society and talked to them. And there's a pretty sophisticated federal process for, providing bona fides for foreign medical graduates. This bill that we passed requires them to have this certificate from this, certifying body, this federal certifying body. And part of gaining that certificate is you have to have done a residency equivalent in a certain, in a sophisticated country, and you have to have proficiency in English. You have to show proficiency, test out in proficiencies in English. And so it may just be that there's not a sophisticated system in some of these other professional, industries like we have in medicine, because we have had a lot of, international people move to Arkansas to practice medicine. And I'm grateful for them being here. They fill a great role. And so because we've had such a surge, I think there's, maybe a more sophisticated process in trying to vet them and make sure they've got, the qualifications to actually get a license and practice safely.
Matt, I've got one more question. Do you have anything before I do this last one?
You nail it. Go roll
All
with
right.
it.
I'm curious. We didn't talk about it, but maybe we can just talk about it briefly. The bill that was passed, Act 624 on the PBMs, the pharmacy benefit manager. I think I understand it. But tell me what gets everybody wrapped around the axle and why this is important or not important, or, what we should care about.
I think what the community pharmacists would say, I think, and I'm careful not to speak for them. We have two community pharmacists in the legislature. We have one, a senator and a state rep who practice, are practicing pharmacists. And so, I try to stay in my lane with this particular issue. But this idea of vertical integration where you're both the insurance company and the provider of the medication, it creates a system where there can be a lack of fairness, from a competitive standpoint. I think the main issue, for the community pharmacists is, look, we just want a fair shake. Like if you PBM own pharmacy A, and you're going to give them this drug at price A, we want you to give us a chance to have that same pricing, right? And that's where a lot of this fair and reasonable comes in. They want fair and reasonable. And I'll ask a pharmacist once, what is fair and reasonable? They seem like synonyms to me, right? Well, fair is I'm going to pay you $20 for a drug, and I'm going to pay everybody else. It would be unfair for reasonable. Reasonable would be I'm going to pay $20. Unreasonable would be I'm going to charge you $5,000. So what's a reasonable price? And then fair is whatever we decide that reasonable price is, we're going to distribute it across all players in the marketplace. And I think they would say that this vertical integration the PBMs has created a both unfair and unreasonable approach to the cost and delivery of drugs through a pharmacy that puts them at a disadvantage that it makes it very difficult for them to stay open to practice. And where it does kind of dovetail over into medicine is you're seeing some of that vertical integration with healthcare too, right? I mean, companies like United Healthcare are hiring, employing clinical providers in the same sort of vertical process that you're seeing through the PBM. So it's going to be real interesting to see how that plays out. It's going to get settled in a lawsuit, for sure. But we went through this in 2017 with the PBM Licensure Act. We were one of the first states to have something like that. And I think, we're sort of tip of the spear with this issue as well. And it's going to be interesting to see how it plays out. I can see the other side too. I mean, if CVS truly pulls out all of its pharmacies, are there deserts that creates that weren't there before? Potentially in places, but the good news is we also passed legislation this session to allow hospitals who previously couldn't have pharmacies to have retail pharmacies. So you're closing one door, opening another door in the same legislative session. And I think you're going to see people with the ability to get their medications. I don't think they're going to feel it the way it's being touted. But time will tell.
Yeah, we'll see. Well, just as some talking points on it, 80% of all prescriptions claims in the U.S. are controlled through a PBM. That's 3 out of 4 prescriptions that are written. And CVS has 23 locations in Arkansas. They've threatened to shut down.
Can we circle back? Can we circle back to one thing before we go?
Sure.
Because I wanted to, you mentioned it, and I didn't really get to talk about it much. This issue around Medicaid recipients not having a primary care physician. So those numbers, the numbers that I remember them saying in our public health meeting was, there was not every Medicaid recipient requires a PCP. And there were around 500,000 Medicaid recipients that require PCP. 145,000 of those don't have a PCP required, or don't have one assigned. So there are 145,000 Arkansans, and this just came up in this meeting, right? I was totally unaware of this number. And it was a stunning number to me to hear that there's 145,000 Arkansans that are on Medicaid that just don't have a PCP assigned to them. And I think that I don't want to be critical of that, but I look at it as a real opportunity, right? Because, why do they not, this gives us a chance to really dig in. Did they not have a PCP, to your point, because there are no PCPs? Or is there some logistical issue? When they get enrolled in Medicaid, the process, as I understand it, is they get a letter that says, hey, this is the number you call to get a PCP assigned to you. If that's all we're doing, do we just need to tell these patients, these citizens, hey, call and get your PCP? And we asked for a bunch of information there that I think is going to be real interesting. We need demographics on those people. Like, of those 145,000, how long have they been on Medicaid? Are there, have they been on Medicaid for 5 years and they still haven't gotten a PCP? And how often are they accessing the system? And how many times do they come to the urgent care and the ER? And how old are they? Are they kids? Are they adults? And, it's a real opportunity to kind of dig into this problem and try to find a solution, right? I don't think you can find a solution to the problem until you really know what the factors are and the data is around the problem. And I'm grateful we discovered that there's this many people without a PCP, because I do think within that discovery is some real opportunity to dig in and kind of try to address some of these access to care issues.
Yeah. There's a lot to talk about. Even if you just take 1.2 million people and you assume they all want the best care they possibly can get, and they require over time more sophisticated equipment with more sophisticated specialists, that means the price is going to rise. And and healthcare is something that has risen substantially higher than other, inflation, et cetera. It's right up there with education and housing. It's so. Matt, you want to shut us down?
Yeah, well, thank you so much, Doc Johnson, Lee the Soul Man Johnson, as I've now deemed him, representative of Greenwood and all around great guy. And I'm so glad you're in the House of Representatives, not just for my selfish needs when you helped put my jaw back into place, but just to have you there. I think you do a great job representing the people in your district, and you've always been a pleasure and a professional to deal with. So thank you so much for your service.
You know, I love it, Matt. I enjoy the opportunity and the privilege to come down there and serve and try to make Arkansas a better place. And I appreciate y'all having me on. This was a great conversation. Happy to come on again at some point. There's, like, to your point, Andy, there's an endless amount of things you could discuss around healthcare. Getting down to the nuts and bolts of, what are the policy levers that we need to pull. I think, it's easy to identify the problems, but then, to your point earlier, how do you fix them? I think, yeah, it is. But you don't ever get anywhere unless you start having those conversations and invite people to reach out to you and say, hey, here's an idea I have to try to solve a problem. And that's the great thing about Arkansas. It's a small state, and as long as we're all talking to each other, there's a lot of good minds out there to come up with good solutions.
Excellent. Yeah. Lee, thank you very much.
Yeah, it's great to see y'all, guys.